Welcome friends to the new episode of our YouTube series How Do Expert Manages It. Since the videos are posted on YouTube, one can watch and listen it as and when time permits them. Our today's subject is abdominal hysterectomy, triumphing the techniques. Our expert faculty today is Dr. Munjal PANDYA. Dr. Munjal PANDYA is consultant obstetricians, gynecologists and academicians from Ahmedabad. He is an assistant professor at AMC Medical College, Ahmedabad, Gujarat. He is also a joint secretary of Ahmedabad Obstetrics and Gynecological Societies for the current year 2020. He has received Series Daftari Young Talent Award from AOGS for the year 2017-18. He has remained a faculty at state and national level conferences. He is a co-edited book on male infertility in January 2019. He has published many papers and many chapters in different books.
Starting with the procedure, routine preoperative examination is must, followed by blood investigations, ultrasonography, and special investigations as the case may be, like MRI, intravenous pyelography. One of the most important investigations which has to be done before proceeding with hysterectomy is recent Pap smear. In cases of huge fibroid or compressing fibroid or adnexal masses, intravenous pyelography can be opted before proceeding with the procedure. Vaginal cavity is to be prepared with povidone iodine before the start of procedure. The position of the patient can be supine or modified lithotomy with Allen stirrup. Urethral catheterization is preferred, and anesthesia may be regional as in spinal or general anesthesia according to the patient. The operator usually stands on the left side of the patient for easier and more access of the pelvic cavity when it comes to pelvic surgeries. Abdominal incision usually in routine abdominal hysterectomies is phalangeal, or it can be any other incision as comfortable to the surgeon. When it comes to previous abdominal or pelvic surgeries, there might be adhesions. Now these adhesions need to be removed to restore the pelvic anatomy as much as possible before proceeding with any other steps of the surgery. Intestines are to be packed and pushed upwards towards diaphragm, clearing the fields and preventing them from coming in between the operative field. A pair of calyx forceps are to be applied on both the cornua to pull the uterus upwards and outwards for further steps. The next step is ligation and division of round ligament. With continuous upward and outward traction on uterus with calyx forceps, 2 clamps are applied on round ligament approximately 1.5 to 2 cm from the cornual structures. The round ligament in between is cut and the pedicle on the lateral side is ligated with 1/0 absorbable suture. One more method of cutting, clamping and ligating round ligament is application of 2 sutures approximately 1.5 to 2 cm from cornual structure and afterwards cutting the round ligament in between. Now we have entered the broad ligament. The broad ligament is lifted with the forceps and all of the subperitoneal connective tissues are detached with the Cooper scissors, or also known as fine scissor. Now in this particular step, the peritoneum needs to be separated from subperitoneal connective tissue to avoid unnecessary oozing and obliteration of the operative field. This particular step is important also in cases of detachment of ureter, urinary bladder and rectum from neighboring tissues. As we can see on the left side, it is a poor dissection of peritoneum, and on right it is very fine dissection with detachment of almost all of the subperitoneal connective tissue from the peritoneal surface. Next step, clamping, cutting and ligation of ovarian ligament and fallopian tubes, also popularly known as infundibulopelvic ligament. The ovarian ligament and the fallopian tubes are clamped with Heaney's forceps and Cocker's forceps and cut. Double ligation of infundibulopelvic ligament is a preferred step. If the adnexal organs are to be conserved, the clamp can be placed accordingly. If the ovary is to be preserved, the clamp has to be applied medial to the ovary. In case of salpingectomy, mesosalpinx is clamped, cut and ligated, and a proper precaution needs to be taken to avoid compromise of ovarian blood supply. Posterior part of broad ligament is incised, target endpoint of this particular incision being the uterine origin of uterosacral ligament. After repeating the same procedure on the other side, we will proceed with mobilization of bladder. With strong upward traction on the uterus and lifting the incised bladder peritoneal stump with smooth forceps, increasing the tension. First, mobilize the bladder with fine scissors at the center of cervix. Then proceed with lateral blunt dissection with Cooper scissors to expose vesico-uterine ligament. The bladder should be mobilized at approximately 1 cm below cervico-vaginal junction. If there is bleeding, the bleeding point is coagulated with bipolar coagulator, remaining as superficial as possible. The key points: always remember the back of the bladder bleeds easily. To avoid ureteral injury, it is very important to keep the uterus under constant upward traction and at the same time pushing bladder downward with the retractor. Next step, clamping, cutting and ligation of uterine artery and the vasculature along with cardinal ligament. This procedure is very important to keep ureter away from the uterine cervix, especially when there is inflammation or endometriotic adhesions near uterosacral ligament. Skeletonization of uterine artery is to be done gently. Clamp the uterine vessels and cardinal ligament slightly below the internal os of uterus with Heaney's forceps so that uterine side can be sandwiched with a short Cocker's forceps to control retrograde bleeding from the uterine side of uterine artery and then divide the pedicle. Uterine artery needs to be doubly ligated for securing hemostasis. Few key points: sliding of the clamp has to be done to avoid any raw area which may ooze later on. Cut the pedicle till just beyond the tip of the forceps. The placement of suture is again very important. It has to be at the tip of the clamp so as to avoid any raw area which would obstruct or obliterate the field of operation. Performing any of the precautions incorrectly interferes with subsequent surgical steps. Now push down the stump of uterine artery and upper part of cardinal ligament. Retract the uterus strongly upwards to the opposite side. Compress the cut stump of the cardinal ligament and uterine vessels with gauze gently and push them down slowly 1.5 to 2 cm along the cervix to the level of uterosacral ligament and vesico-uterine ligament. As shown in the figure on the right side, the pedicle has to be pushed down properly for application or proper application of the next clamp. Proceeding with uterosacral ligament and posterior half of cardinal ligament, which is again known as second step of parametrial tissue cutting. The uterosacral ligament is cut and ligated and the ligature is gripped and retracted. Many of us would like to keep one of the thread of this particular pedicle long and have artery forceps at the end so as to demarcate the structure later on. Moving on to vesico-uterine ligament now with anterior half of cardinal ligament, which is again known as third step of parametrial tissue cutting. Place the right hand against the back of cervix. Check the cervicovaginal junction again. An inverted T incision can be kept, which is also known as modified Richardson technique, where the bladder fascia is again further pushed down and the next clamp can be applied intrafacially. Vesico-uterine ligament and anterior part of cardinal ligament are clamped, cut and ligated, and the ligature is again something which can be ligated with the ligature of uterosacral ligament. Clamp the vaginal wall at cervicovaginal junction. Palpate the uterine cervix again from the front and back to identify the boundary and clamp the vaginal wall with right angled forceps or heinous forceps. If the rectum adheres to the posterior wall of cervix and is raised when the cervix is also raised, incise the adhesion at the border with an electric knife and push down slowly, and then clamp the vaginal wall so as to secure or prevent injury to the rectum. The step is repeated on the other side. Now a large gauze is placed on the posterior side of uterus and the bladder is elevated with the bladder spatula, and the anterior wall of cervix is incised with an electric knife. When the vaginal space is partially opened, grasp the vaginal wall with a long straight coccus forceps. Hold the vaginal wall with long straight coccus forceps at 3 or 4 points and remove vaginal secretion and disinfect vagina. This particular thing can be done by applying povidone iodine on portio and vagina. I would like to highlight one technique that is known as close technique at this particular step. This technique is beneficial in decreasing spillage of vaginal contents into the abdomen. This technique decreases the risk of infection and formation of symptomatic granulation tissue at the vaginal apex. A curved hinge is placed across lateral vaginal apex with its tip extending across the upper vagina, immediately beneath the cervix. A similar placement on the other side allows two heinous clamps to meet in the midline. Anterior and posterior vaginal mucosa is trapped within the clamp by this technique and does not need to be identified separately. Now bilateral ends of vaginal stump are sutured with 1-0 absorbable suture and the remaining part is sutured continuously. Usually absorbable sutures are used to avoid complications at the wall. Hemostasis is to be achieved. With regards to reperitonization, there are again controversial views, but a few of the studies suggested that reperitonization is not necessary unless hemostasis of the peritoneal edge is a concern. New mesothelium arises from the subperitoneal connective tissue cells, not from the adjacent peritoneal edge, and occurs simultaneously in all exposed areas, independent of the size of the defect. Attempts to cover areas of peritoneal injury may lead to increased adhesion formation at the sites of reperitonization by preventing autolysis of early fibrinous attachments and introducing reactive responses to suture material. In some cases, vaginal cuff needs to be kept open. In cases where drainage of pelvic cavity through vagina is desired, such as surgical intervention for active pelvic inflammatory disease, unresponsive to antibiotic therapy, vaginal walls are sutured inside out through full thickness interlocking. T-tube or drain can be placed through open cuff with its end into vagina. To maintain it in a retroperitoneal position, anterior and posterior peritoneum are sutured. Hemostasis is one of the most important points to be kept in mind with relation to the source of energy, application of energy, and the site. When stopping hemorrhage at the parametrial tissue of uterus, always keep in mind that the ureters run very close to the bleeding point. When bleeding occurs, do not immediately stop the bleeding with panicking clamp or self-missing sutures. Therefore, first push the gauze to the bleeding area, maintain transiently the hemostatic condition, and wait a little bit. During this waiting period, the operator can escape from panicking time and will consider the most appropriate recovery with pinpoint holding of that particular hemostatic point. Next step is lavaging of abdominal cavity with closure of abdominal wall. Additional suturing, if required, would need re-evaluation of proximity of ureter, which can be diagnosed by two methods majorly. One is usage of intravenous indigo carmine coupled with a small cystotomy incision. The other method is a small cystotomy incision followed by retrograde placement of ureteral catheter to identify the presence and location of suspected occlusion. Now, this particular catheter placement may be helpful in diagnosing partial occlusion or kinking of ureter, which would benefit from immediate surgical release and may not be detected with the usage of indigo carmine dye. After confirming gauze and instrument counting, lavage abdominal cavity with warm saline, return the intestines to their original position, and close abdominal wall. After closing, a post-speculum examination needs to be done. With regards to prophylactic oophorectomy, an informed consent has to be taken. Current scientific evidence suggests that elective oophorectomy is not advisable for majority of females as it may lead to a higher risk of death from cardiovascular disease and hip fracture and a higher incidence of dementia and Parkinson's disease. Recently, it has been concluded that preserving ovaries until at least age of 65 years was associated with higher survival rates. Highlighting few key points. Abdominal hysterectomy is indicated only when vaginal hysterectomy or laparoscopic hysterectomy is not possible, but again it is the first step towards learning hysterectomy. Examination under anesthesia is very important step and must not be missed. Appropriate exposure of pelvic organs is must, as we already saw that removal of adhesions are must before proceeding with further steps. Good anatomical knowledge and appropriate surgical techniques are must to avoid any kind of complications and proceeding smoothly with the procedure. Stay medial to the previous clamps. Double clamp and double ligation of pedicles is must whenever there are vessels in those pedicles, and hemostasis is must, which needs to be checked at all pedicles before closure of abdomen. Thank you. Thank you, Dr. SUDHIR Shah sir, for guiding us all throughout this particular presentation and keeping it compact so that people would get advantage from it. And thank you so much, sir, for creating this particular platform for enlightening the generations to come. Thank you so much, sir.
Thank you very much, Dr. Munjal Pandya, for a very interesting and educative talk with slide presentations on our day-to-day practice. Friends, please share this link to your friends, your colleagues and your students. Please subscribe this channel. Thank you.